Hello students, good morning. I am Dr. Ranganathan from Department of Orthodontics and Dentofacial Orthopedics. I am going to talk about method of gaining space in orthodontics. During orthodontics treatment, space is required to move the mesial location of the teeth, correcting crowding, retraction, intrusion, leveling of curve of P, derotation of anterior teeth, correction of molar relation. Methods of gaining space. Two things we have to concentrate, either by extraction or non-extraction. Extraction method, conventional extraction and unconventional extraction. Non-extraction methods, proximal stripping, arch expansion, molar dislocation and molar uprighting, derotation of posteriors and incisor proclination. When to employ non-extraction methods? Mild to moderate space requirement, constricted arches, no skeletal component of malocclusion, no need to alter the facial profile. These are the conditions. Reproximation during proximal stripping and slenderization, disking, interproximal stripping and proximal slicing. Proximal stripping. Proximal stripping surfaces slice to reduce mesiodistal width of the teeth. That is conservative method. During mild to moderate crowding, 0.2.5 millimeter moderate crowding routinely carried out in the lower anterior region. Indications of proximal stripping: 0 to 2.5 millimeter space requirement, Bolton excess or discrepancy, aid in retention, maintain the profile, maintain class 1 and molar relation. Contraindication of proximal stripping: young patients with large pulp chamber, high caries index, poor oral hygiene, enamel hypoplasia. Advantages of proximal stripping: borderline to non-extraction patients, favorable overjet and overbite can be established to match upper and lower tooth material. There will be more stable results. Contact areas are bordered. Disadvantages of proximal stripping: rough and proximal surface, block, ledges and grooves, excess tooth material reduction, increased caries susceptibility and sensitivity, alteration of tooth morphology, loss of contact and food impaction. Diagnostic aids: caries analysis, Bolton analysis, intraoral periapical radiograph. Procedure: not more than 50% thickness of enamel thickness is reduced. That can be used by metallic abrasive strips, safe-sided carborundum discs and long thin tapered fissure burr. You can see in the picture how proximal stripping is done, how the space is created by proximal stripping. Then proximal surfaces must be shaped naturally as possible. Polishing and topical fluoride application should be done. No effects on interproximal tissues and bone. That should be concentrated during this procedure. Next is molar dislocation. Indications of molar dislocation: growing child with class 2 molar relation to relieve the mild crowding in anteriors in case of class 2 mesially moved conditions. Late mixed dentition when lower east space is utilized for relief of anterior crowding. Upper molars dislocated to get a class 1 relation. Contraindications of molar dislocation: non-growing patients with class 2 molar relation to regain lost arch length. Upper second molar extraction cases: lack of space for eruption of premolar due to mesial migration of first molars. Case selection for molar dislocation: there should be a good soft tissue profile and dental class 2 cases. Borderline cases: mild to moderate space discrepancy. Third molars and second molars are not yet erupted. End on molar relation or class 2 molar relation. Late mixed dentition is ideal. Early permanent dentition, growth still left in maxillary tuberosity area. 16 to 17 years in males, 14 to 15 years in female patients. Molar placed normally and buccopalatally. High mandibular plane angle, contraindicated in wedging effect. Classification of molar dislocation. Location of appliance: extraoral appliance and intraoral appliance. Position of appliance inside the mouth, buccal or palatal. Type of tooth movement, bodily movement or tipping movement. Molar distalization, complaints needs from the patient. There will be a maximum complaints or minimum or no complaints from the patient side. Type of appliance, removable appliance and fixed appliances for molar distalization. Arches involved, intra-arch or inter-arch. What are the appliances used for molar distalization? Headgears, pendulum appliance, coil springs, night tie and stainless steel. Distal jet appliance, K-loop, Jones jig, magnets, modified Nance lingual appliance, transpalatal arch, micro screw implants. Distalization using headgears. Using headgear for distalization is very efficient. Reciprocal forces are not transmitted to other arch. Important. Molar movements depends on direction of force in the relation of center of resistance of the molar and magnitude of force. Disadvantage, patient compliance. Cervical headgear. Next is cervical headgear. We can see in the picture cervical headgear, short face and class 2 maxillary protrusive cases. There will be a short face, class 2 and maxillary protrusive cases with low MPA and deep bites. Extrusive and distalizing effect by using cervical pull headgear. High pull headgear. Long face, class 2 patients with high FMA. Force through center of resistance, intrusion and distal movement of the molar. Straight pull headgear. These are the extraoral appliances. Class 2 malocclusion with vertical problems. Prevent anterior migration of maxillary teeth, then it will be translated posteriorly. These are the distalizing appliances. Nance button is connected to the first premolar for anchorage. Where you can see the Nance button in anterior here for anchorage purpose. Then by using the K-loop compressed and inserted, then it will be distalizing the molars by using the Nance palatal arch as an anchorage. The premolars will not facilitate mesial migration because of Nance palatal arch. Then molar will be distalized automatically with the support of Nance palatal arch posteriorly. That is why the distal movement of the molar occurs because of this appliance. So Nance palatal button prevents the mesial movement of the premolars. Then the molar is distalized. This is Nance palatal button. This prevents the mesial movement of the premolars. Then anchorage is obtained. Then the molars, both the sides, it is distalized. So distalization of molar by repelling magnets. Magnets are used to distalize the molars easily, and that can be done with Nance button attached to first molar. Repelling magnets between first molar and first premolar. So again the same thing, Nance palatal button prevents mesial movement of the premolars, resulting in molar distalization. Molar distalization with superelastic night eye arch wire. Pendulum appliance. That is another important appliance which is used intraorally to distalize the molars. Nance button to first premolar for anchorage. 0.02 inch TMA springs that can be embedded in acrylic inserted into the molar by lingual sheath. You can see the lingual sheath on the molar side, both the sides. Then broad swing arc pendulum of force from the midline of palate to upper molars to produce the distalization. Then this is connected to the lingual sheath. Then the molar distalization occurs with the pendulum appliance. Distal jet appliance. See in the picture, acrylic button for anchorage is attached to the second premolar. Tube and clamp from the acrylic is inserted into the lingual sheath on a molar band. A compressed coil anchored to the clamp is the active unit. Where you can see the compressed coil here. This is active unit where there can be a molar distalization possible by using the distal jet appliance. Open coil jig. 90 coil spring on a heavy round wire, and the Nance button is attached to the second premolar. You can see Nance button is attached to the second premolar. Then the spring acts with the heavy round wire. Uprighting of molars. Sometimes molars will mesially drift because of before the eruption of second premolars. Extraction of second premolar, early loss of E causes mesial tilting of the first permanent molar into that place. Early loss of second premolar or extraction of E, tilting of permanent first molar into that place leads to mesial drifting of first molar. Tilted molar occupies more space, so that should be uprighted. So that's why we use uprighting springs to upright the molars. Whatever space is gained, that can be retracted to close the space. So we have seen about method of gaining space by extraction and non-extraction method, proximal stripping, distalization of molar and headgears. So you have an outline how to answer this question. This will be an important main question. Thank you.